Namaste from India. I am Dr. Somya Puri. I'm a non-acad JR in Department of Ophthalmology in AIMS Bilaspur. So today I'll be discussing the topic ophthalmological complications of cardiovascular and other lifestyle diseases. In this presentation, we'll cover lifestyle and cardiovascular diseases affecting the eye and their manifestation, including diabetic eye disease, hypertensive eye disease, computer vision syndrome, and others. Before moving to the manifestation of the disease, let's have a look at the burden of diabetes globally. According to a study conducted by Global Burden of Disease 2019 Blindness and Vision Impairment Collaborators, it was found that in adults 50 years of age and older, diabetic retinopathy was the fifth leading cause of blindness and of moderate and severe vision impairment. In particular, age standardized global prevalence for blindness resulting from diabetic eye disease has increased by 14.9% to 18.5% from 1990 to 2020. In another study conducted by International Diabetes Federation, it was estimated that global population with diabetes mellitus uh, is 463 million was 463 million in 2019 and is predicted to be uh, of the value of 700 million in 2045. In the same study, it was also found that the prevalence of diabetic retinopathy was 22.27% among the diabetic patients, and prevalence of vision threatening diabetic retinopathy was 6.17%, whereas CSME prevalence was 4.07%. Looking at the disease burden in India, according to a study by Raman et al., in India, 77 million people have diabetes, and this is predicted to increase to 125 million by 2045. This means that one out of every five individuals in India uh, is expected to be diabetic right now. Another study, cross-sectional study, conducted in people aged 40 years and older across 10 Indian states and one union territory, it was concluded that prevalence of diabetic retinopathy in India was 12.5%, and that of vision-threatening diabetic retinopathy, it was 4%. So it was very close to the values that were concluded in the study conducted globally. So, looking at the so as we can see that diabetes and other lifestyle diseases, they affect many organs of our body, including the eye. And in the eye, it not only affects the retina, causing diabetic retinopathy, but also other parts of the eye, starting from the cornea. In cornea, diabetes decreases the corneal sensation, that leads to recurrent endothelial defects, recurrent corneal ulcers that are difficult to heal. In iris, due to the chronic retinal ischemia and increased release of VEGF, there is neovascularization not only in the retina but also sometimes on the iris that leads to rubeosis iridis. In the cataract, due to conversion of glucose to sorbitol, which is an osmotic agent, there is increased accumulation of fluid inside the lens that leads to cataract and various refractive changes. In the vitreous, it leads to vitreous hemorrhage, vitreous detachment, and in the retina, it causes diabetic retinopathy, diabetic maculopathy, CRVO, BRVO, tractional retinal detachments. It also affects the optic nerve, causing diabetic papillitis, optic neuritis, and glaucoma. Due to the pathogenesis of diabetes causing damage to the small vessels, it also damages the small vessels supplying cranial nerves, innervating the extraocular muscles, which are the third, fourth, and sixth cranial nerves. This leads to cranial nerve palsies that manifests as squints. Now, the pathogenesis of diabetic retinopathy, it mainly occurs to two main pathways. Any complication in diabetes occurs to mainly two pathways, that are non-enzymatic glycation and sorbitol accumulation. Retinopathy is one complication of diabetes that occurs due to both of these pathways. So what happens is, due to hyperglycemia inside the vessel, it increases the retinal blood flow. This leads to damage to the endothelial cells and increases the oxidative stress and inflammatory reaction inside the blood vessel. This leads to blood retinal barrier breakdown and loss of pericyte around the blood vessel. This causes endothelial cell migration and formation of microaneurysms. So these microaneurysms are prone to rupture, and this causes hemorrhages on the retina. And all this also leads to increase capillary hypoperfusion and chronic retinal ischemia. That leads to release of various growth factors, especially vascular endothelial growth factor, that leads to increased proliferation of new blood vessels, neovascularization inside the retina, and also increases the vascular permeability, leading to exudate formation and edema. So, manifestations of diabetic retinopathy inside the fundus is mainly divided. It's mainly divided into three types. That is non-proliferative diabetic retinopathy and proliferative diabetic retinopathy and maculopathy. So, initially, the first step is the pathogenesis of diabetic retinopathy is retinal hypoperfusion, retinal artery dilation. So this is a fundal picture showing early diabetic retinopathy changes. And then non-proliferative diabetic retinopathy is further divided into three main types: mild, moderate, and severe. In mild diabetic retinopathy, there are only a few microaneurysms present in a single quadrant. And in moderate non-proliferative NPDR, there is presence of increased number of microaneurysms along with dot and blot hemorrhages, as seen in this picture, dot and blot hemorrhages, and hard exudates that present as yellow colored spots on the retina. This is as a consequence of leakage of lipid from the damaged vessel that deposits and presents as yellow colored dots on the retina. And along with this, there could be sometimes soft exudate also present. And in severe NPDR, this is clinically diagnosed by 4 to 1 rule, 4 quadrants of diffuse retinal hemorrhages and microaneurysms, more than equal to 2 quadrant of venous bleeding, and more than equal to 1 quadrant of iron. Then the next presentation is proliferative diabetic retinopathy, that is PDR. This is as a consequence of chronic retinal ischemia that leads to release of VEGF and increased proliferation of new vessels inside the retina. These new vessels are very fragile and easily rupture and lead to hemorrhages inside the retina. So there is an increased incidence of vitreous hemorrhages, retinal detachment in cases of PDR. Then the third presentation is diabetic macular edema, or DME. This is clinically diagnosed by presence of retinal thickening at or within 500 micrometer of foveal center, or hard exudate within 500 micrometer of foveal center. So this picture shows hard exudate within 500 micrometer of the foveal center. So this raises a suspicion of presence of DME. To confirm this, OCT is done, and this shows an OCT picture showing fluid accumulation inside the retina, which confirms DME. Now, moving on to other other retinal manifestations of diabetes. So it can also present with pre-retinal hemorrhage, that is blood present between posterior hyaloid and internal limiting membrane of the retina. So this clinically presents, the patient clinically presents as a complaint of dark colored boat-shaped floater in his vision. And this is a fundus picture showing the boat-shaped hemorrhage and OCT for the same. Then it can also lead to vitreous detachment, or that can be seen as floaters inside the vitreous, and or branched retinal vein occlusion. This is seen as streaky hemorrhages present on the fundus. And tractional retinal detachment. This is increased. This has increased incidence in cases of PDR patients. So this shows detachment of the retina. Now, non-retinal manifestations of diabetes include recurrent stye or blepharoconjunctivitis. These are sometimes the first indication of diabetes, and this should prompt investigation regarding diagnosis of diabetes. Corneal sensitivity and recurrent corneal ulcers, as we discussed before, and glaucoma can also be seen in diabetic patients. This is associated with narrow angle glaucoma more than open angle. This is caused by closure of angle by swollen lens or iris neovascularization that blocks the outflow of the aqueous humor. It can also present as cataract that usually have earlier onset due to sorbitol-induced swollen lens. Then diabetic papillopathy and cranial nerve palsy is leading to squint. Now moving on to the second presentation, second lifestyle disease in eye, hypertensive eye disease. So in a 3-year population-based cohort study of atherosclerosis risk, the incidence of stroke events were more common in participants with signs of hypertensive retinopathy than in participants without retinopathy. Uh, it was particularly more common in patients with hypertensive fundal findings of cotton wool spots, followed by microaneurysms and blot hemorrhages. In an analysis, it was found that moderate signs of hypertensive retinopathy were associated with 4-fold higher risk of incidence of stroke event. And some investigators also suggested that if there is a presence of moderate hypertensive retinopathy changes, that could be used as a predictor of incidence of congestive heart failure, even in individuals without a previous history of MI. So, hypertensive retinopathy manifestations are further divided into 3 types: mild, moderate, and severe. In mild retinopathy, there is only retinal arteriolar signs that include arteriolar narrowing and AV nipping. This picture shows mild hypertensive retinopathy changes. It shows narrowing of the vessel and AV nipping. And then moderate retinopathy would be recognized by flame-shaped hemorrhages. These are some flame-shaped hemorrhages and cotton wool spots. Sometimes hard exudates can also be present in hypertensive retinopathy and some microaneurysms. In severe retinopathy, all these findings like cotton wool spot, flame-shaped hemorrhages, hard exudates, microaneurysms, along with evidence of optic disc swelling. So this also shows optic disc swelling to basically whenever there is presence of disc swelling, the margins of the disc are not defined and they fuse with the surrounding retina. So this shows disc swelling. This shows bilateral disc edema. The margins of the disc are not defined. Now, moving on to other manifestations of hypertension, these include retinal vein occlusion. This shows a picture of branched retinal vein occlusion. So this can be a manifestation of either hypertensive retinopathy or diabetic. So this presents as streaky hemorrhages on the fundus, and there can also be retinal emboli, retinal artery occlusion, especially central retinal artery occlusion. This presents as presence of a red spot in the foveal center surrounded by whiter area uh, around. So this clinical finding is known as cherry red spot on the fundus and retinal microaneurysms. So association of hypertension with any of the above ocular manifestation is shown to have an increased risk of cardiovascular diseases. So it is important to identify and classify the patient having having any hypertensive retinal findings, so that we can manage and prevent further deterioration of the patient. So moving on to the third lifestyle disease manifestation in eye, this includes computer vision syndrome. So because of the COVID pandemic, the screen time of every individual throughout the world has increased drastically. So average American spends 7 hours per day on the computer. According to the Vision Council, at least 60% of American men and 65% of American women reported symptoms of computer vision syndrome. 80% of adults use digital devices for at least 2 hours daily, and more than 65% of adults use at least two devices simultaneously. So all these increased screen time leads to various symptoms in the eye that include eye strain, headaches, dry eye syndrome, burning sensation, a feeling of foreign particle in the eye, watery eyes, blurring vision, redness, and itchiness in the eye. So, according to American Academy of Ophthalmology, uh, they have suggested a fixed recommended hours on screen time according to the age group. So in infants, there are no recommended hours. That is, the infant is not uh, recommended to spend any screen time. And in children aged 1 to 2 years or 3 to 4 years, the set point is 60 minutes or less. And in adults, it is expected to be less than 2 hours per day. So, as we know that all these manifestation uh, result as a consequence of increased screen time, so they have to be prevented or managed. So, how can we prevent these symptoms? First of all, there should be an arm's length distance between the screen and yourself, which accounts to approximately 20 to 25 inches. And following the 20-20-20 rule, that is, every 20 minutes, an individual should take the eye off the screen for about 20 seconds and look at a distant object situated 20 feet away. Also, adjusting your room lighting and increasing contrast on your computer is also contributes to decreasing the amount of stress on your eyes. Then the last resort is usage of artificial tears to um, help in the symptoms of dry eye. Then other lifestyle diseases affecting the eye. So various lifestyle habits like smoking, alcohol use, or inadequate diet also increases the risk of development of certain eye conditions. For example, age-related macular degeneration. So this is degeneration of the macula that occurs with age. Although the risk of developing this disease is increased with hypertension, smoking, carotid artery disease, alcohol, or imbalanced diet. This ARMD is also linked with high risk of stroke and cardiovascular mortality, and this can be managed by multivitamin supplementation. This only proves to slow disease progression. And another lifestyle disease impact on the eye is age-related cataract. So this has increased risk by with smoking, alcohol, or light exposure. So, as we have discussed, all the common ocular manifestations of lifestyle diseases, it is important that we have a plan in our mind to manage all these or prevent all these complications from occurring. So, the foremost method of preventing any ocular manifestation that we have discussed so far is a regular screening of ocular manifestations of lifestyle diseases once disease is diagnosed. For example, in cases of diabetes mellitus, so if a patient in type 2 diabetes mellitus, the disease is usually asymptomatic in initial years, and in initial years only the treatment options are most effective. So, in cases of type 2 diabetes mellitus, the screening should start immediately as the patient is diagnosed with type 2 DM. Whereas in cases of type 1 DM, the screening is started after 5 years. Then balanced diet also promotes prevention of certain eye manifestation, for example, ARMD, as we discussed. And quitting smoking, quitting alcohol also decreases the risk of all these ocular manifestations. Specific preventive methods for computer vision syndrome include reducing screen time, the 20-20-20 rule, increasing outdoor work, adequate sleep, and physical activity is also important. So, concluding my presentation, I would like to say that regular screening for ocular manifestation guides the patient is very important, and it helps in guiding the patient about intensity of lifestyle control that is needed by the patient. For example, regularly screening the patient for diabetic retinopathy changes will guide the patient how efficiently he has to uh, work on his glycemic control, and prevention of development of vision threatening complication, and once developed helping to slow further progression is also one of the advantages we get by regular screening and identifying the ocular manifestation of these lifestyle diseases. Some ocular manifestations have proven to be predictors of risk of cardiovascular diseases, disease development like MI and stroke, as we discussed in hypertensive retinopathy or hypertensive eye disease. Thus, including ophthalmology consultation in every patient with lifestyle disease will improve the outcome of the patient significantly. So, by this, I conclude my presentation. Thank you so much for paying attention.